Welcome to This Is Getting Old. I'm your host, Melissa Batchelor, and on today's episode, we're going to be talking about atypical presentation of illness in older adults. And I'm joined by Jamie Smith, and she is co-author of Geriatric Notes, which is a practical, concise, up-to-date guide that's specific to geriatric medicine. And so this resource talks a lot about different common conditions, symptoms, and is helpful in clinical practice. So welcome, Jamie. And before we begin, maybe you can just tell us a little bit about yourself and how you ended up writing Geriatric Notes.
Okay. Hi, everyone. My name is Jamie Smith. I'm a nurse practitioner in Southwestern Virginia. I work full-time with Premier Geriatric Solutions. I'm the director of education. I train nurse practitioners and the new people coming on board, and I love it. Prior to this, I've been doing this for 8 years. And prior to this, I worked 5 years as an ER nurse, ICU, stepped down, did a little bit of everything. So Geriatric Notes, when I first became a nurse practitioner, I was completely overwhelmed. And so to help cut back on my stress, I ended up carrying a book around with me, some textbooks like Hazard's Geriatric Medicine, which is a great resource. I just knew after a while I could not keep toting around big resources with me. And so I started making notes of the really good stuff that the textbooks pointed out that I would need to know quick, especially when you're seeing 20 or 30 patients a day. The stuff that you see often, I wanted to have handy. So I took everything that I wrote down off to the side and I turned it around and made it into a pocket guide. And I got it published. Jones and Bartlett picked it up, and I'm glad it worked out the way it did, because we have universities across the United States using it for their students and NPs, RNs. So it's pretty exciting. So
yeah, so I think that's great. And something that we definitely need. So we're going to talk about atypical presentation of illness. And so before we really kind of launch into some specific information, let's just define what we mean when we say atypical presentation.
Atypical presentation means when you have an illness or a condition, something going on, but it's not textbook typical. Atypical means it's not typical.
Okay. And so at the end of the day, that kind of leads us into our first point of today's session, is that this, typically you'll have a family caregiver or a nurse on the floor, or a nursing assistant come up to you and say, Mrs. Jones just isn't right today. That could mean a lot of different things, particularly, so let's talk about that a little bit, maybe what does hypoactive delirium look like, and kind of when, if someone is just kind of lying in the bed, maybe they're, all of a sudden really tired, what can that mean?
So when you have delirium, that acute global change that happens, it happens quickly, sometimes hours to days. And it's usually multifactorial, which means it's not just one thing. It's usually a number of things. And when a patient's hypoactive, that means it can easily be confused with, having a bad day, depression, progressive dementia. A lot of times it gets overlooked. And so they may be more fatigued, sleeping during the day. So it can be very difficult to pick up on. And I love it when the CNAs, they are wonderful. I'll have CNAs because they work so much with the patients in long-term care. They're a lot of times one of the first ones to say, hey, Jamie, will you go see so-and-so because something's not right. I don't know what it is, but can you go check them out? And that's when I do my bedside confusion assessment method. And that can help me diagnose the delirium.
Mm-hmm. And so when we can contrast kind of hypoactive delirium to hyperactive delirium, that's one that's a little bit hard to miss.
Yes.
This is where people are maybe fighting with us, or they're trying to get out of bed, but there's a lot of movement,
That's right.
with this one. So you have a really great acronym to help you think through, like, what would you do in that situation?
So yeah, when I was doing my research on hyperactive delirium, one of the physicians in the chapters was writing what the top common causes of delirium are in older adults. And sure enough, I put together and I was like, oh my goodness, this spells wild. And so W stands for water depletion. That's when a patient's dehydrated. If they don't get good intake, that can mess with, your mind. It can make folks different. And infection is for your eye. So I do a full head to toe exam. I look for Foley catheter, any open wounds, look for cellulitis. I do complete head to toe exam, looking for a possible, source of infection. And then L, labs, I look to see if any recent labs have been done, because if not, their sodium could have acutely dropped, because that can impact your mentation, along with acute kidney injury and other lab abnormalities. And then D stands for your drug effects. I always teach my students, always look for any recent new medicines, because some meds, they may look benign. For example, we may send someone to urology because of overactive bladder, and they prescribe ditropane, and then 2 days later they're completely confused. Who would ever think a urinary medicine could cause sedation? But it can. It's considered anticholinergic. They have what's called a Beers list. It's medicines to use with caution in your older adults. And so I always look for new medicines. I try to reduce medications if they're on anything sedating, like first generation antihistamines or whatever, because drugs are definitely a culprit for change in mentation.
Right. And, when a person has delirium, it is this sudden change. And so we would always say, well, when was the last time that they were right? And then kind of look, that's your look back period.
That's right.
And so I think that's important for nursing students, nurse practitioner students, any healthcare provider, even families, to know to pay attention to your gut. And if the person's off, to maybe watch them for a day or two, whether they have, if they're hyper or hypoactive, but it is something that needs to be reported to your provider.
That's right.
So let's talk about just a couple of different things, maybe how infections present differently for a younger person versus an older person, because that might help people to pick up on things a little easier. So when we think about pneumonia, how does that show up for a younger person?
So younger folks, they may have cough, shortness of breathing, fever, temperature. It may be easier to distinguish with younger folks. Of course, some may have a walking pneumonia, the atypical pneumonia. But from my experience, when I did my clinicals, I found that the younger folks had more of your textbook symptoms more so. Whereas the older adult, a lot of them do not have your typical. I wish they did, because it would make my job easier. But I listen to lungs fully, and a lot of times you won't be able to hear and get. You might be a little unclear on what's going on. Then sure enough, you get the X-ray and it's positive for an infiltrate. Something in their lungs going on. And so a lot of times they'll have vital signs that are abnormal, but it's not textbook abnormal. For example, you might see that their heart rate's in the 90s and they're typically in the 60s. That could be something. And then like the IDSA, Infectious Disease Society of America, there's different definitions of what defines a fever in long-term care. But one of those definitions is when your temperature is 2 degrees higher Fahrenheit than your baseline. And that's something I see. I'll start looking at trends and vital signs, and I'll say, interesting, they're 99.5 to 100. They're typically 96, 97 baseline. So I'll get that X-ray, and sure enough, it'll confirm my suspicions. You may or may not see a cough. You may not necessarily have shortness of breathing, but some of them may have increased functional decline. You might see more falls. CNAs may say, hey, they're not getting up out of bed. They're not feeling like their typical self. The patient may have vague symptoms, like they feel dizzy, or I've even had some complain of GI stuff like constipation and urinary incontinence. And so it's not always straightforward.
Right. And that's actually why I ended up going into geriatrics, because they were always complex and there were all these different layers, but even just on a physical exam, trying to tell the difference between congestive heart failure and pneumonia, and
That's
there
right.
are ways to do that too, because both of them, when you listen to somebody's lungs, they're going to have crackles, but you can use egophony to even tease that out before, getting any type of an X-ray. Okay, so that was pneumonia. And so what about like a bladder infection? So
with bladder infections, those can be tough to diagnose, especially if you've got a dementia patient and something's off. They may have low-grade temperature, they may or may not. Younger adults typically can tell you, hey, it hurts when I pee, which is dysuria. Then peeing more often, they may have urinary urgency, urinary frequency. They may say, my urine is pink tinge or a little off, so like gross hematuria. They may have suprapubic pain, CVA tenderness. They may have like more of your textbook, the younger adults, but then the older adult, it's a lot of times hard to figure out. They may have new onset urinary incontinence, but you have to make sure you differentiate between true UTI versus asymptomatic bacteriuria. In long-term care, asymptomatic bacteriuria is more common than actual UTIs. So I educate that with my nursing staff and CNAs. It's not always straightforward, the UTIs, but I'll ask CNAs, when she pees, have you noticed that she grimaces? Have you noticed that she urinates more than usual? A lot of times I depend on my staff, especially if they've got dementia, because if they can't tell you, then you're not going to know unless you ask your staff.
Right. So it's always trying to solve the mystery. And we are going to do a podcast on asymptomatic bacteria. So that will be, that's another episode that people can look for. And if you have someone who had control of their bladder before, and then all of a sudden they become incontinent or they wet themselves, that's also another indicator they might have, some type of bladder infection. So we want people to be aware of the fact that, urinary incontinence is not a normal part of aging. And if you were fine yesterday and now today you can't control your bladder, it could very well be a bladder infection, or it can be constipation. So it's just, the brain medicine. Right. So the brain and the gut are connected. And with older adults, you just have to start from the beginning and go through everything until you hit on what it is. And so now we'll finish up by talking about kind of how depression looks different in a younger person compared to an older person.
Okay. So younger adults, when I had clinicals, nurse practitioner, when I was going through school, a lot of our younger adults, they were able to say, I am feeling depressed, sad, I've got this or that going on. And you can use your DSM criteria, it makes it easier to diagnose it. But with older adults, I have learned from speaking with my doctors, NPs, and those who do the psyche evals, not to just come out and ask, are you depressed? Because a lot of times they shut down when you ask them that question. So I sit down with them eye to eye and I'll ask them what's going on. Is there anything new going on? I've realized you're staying in your room more. You're not getting out socializing. You used to play bingo with the other residents. You're not doing that. So I noticed like little cues that let me know that they're depressed. They may not verbalize it to you, but they may, their weight may go up. It may go down. A lot of times I'll see weight loss with depression in the older adults. They'll stay in their room, flat effect. And typically we'll ask, do you feel blue, as opposed to just coming out and saying, are you depressed? So.
Right. Well, older adults tend to have a little bit more stigma around mental health issues. But yeah, I think the number one question that I was taught is, are you feeling sad or blue? And then and it's a change in behavior and change in the social engagement. Well, thank you for talking to us today about some examples of atypical presentation of illness in the older adults. And you can visit my website and get a link to geriatric notes. And it's a great resource. There you go. That's the title. That's the book cover. And so any last words before we close out?
No, that's it. Use the code geriatric if you want to save 20% and get free shipping.
All right. That was, very helpful. All right. Thank you all very much. Thanks.
Thank you for joining me for this week's episode of This is Getting Old, Moving Towards an Age-Friendly World. You can find more episodes like this on my YouTube channel, Melissa B. PhD, and don't forget to subscribe. You can also visit my website, melissabphd.com, and check out the podcast and blog section, because that's where I put all the hyperlinks and different things that we may talk about in any given episode. You can follow me on social media, Twitter, LinkedIn, Instagram, and Facebook. And you can also find the audio version of the podcast on iTunes, Stitcher, Spotify, and Amazon Music. So I hope this podcast gives you ideas of different things that we can do to move towards an age-friendly world, because when the world is age-friendly, it's friendly for everyone.